Welcome to Lower Extremity Pathology. In this presentation, we will discuss pathology of the lower limb, including the knee. So let's get started. The first pathology I want to discuss are bone cysts. Bone cysts are benign, neoplastic bone lesions. And when you hear the word neoplasm, remember that just means new growth. It doesn't mean it's malignant. We don't know if it's benign, but neoplasm means new growth. So bone cysts happen to be a growth that are benign, and they are filled with clear fluid. They most often occur near the knee joint in children and adolescents, and you can see an example here in the image. But a lot of times they're not detected until a pathologic fracture occurs at that area. And then the child goes in because they have a fracture here, and then it's determined that they have a bone cyst. So there aren't necessarily symptoms letting someone know they have this. When bone cysts are detected on radiographs, they appear as lucent areas, so less dense than the bone around them, with a thin cortex, so a thin outer shell, and very sharp or distinct boundaries. And you can see that. Usually cysts are very circular. In fact, let me show you another example here. This is a calcaneus bone cyst. You can see the area is lucent, it's filled with fluid, so it's less dense than the area around it, and it's got a very sharp boundary or edge. So cysts are usually very circular. All right, next, chondromalacia patellae. This is a condition that we better know as runner's knee, and this involves a softening of the cartilage underneath the patella, and that results in erosion of that cartilage over time, which causes pain and tenderness in that area. People who are most affected from chondromalacia patellae tend to be cyclists or runners, people who are using this joint a lot. So again, cartilage under the patella gets softened and eroded away, which causes pain and tenderness. So please know that chondromalacia is also known as runner's knee. Next, gout. Gout is a form of arthritis that may be hereditary. And remember, in gout, uric acid appears in excessive quantities in the bloodstream, and they may be deposited in the joints and in other tissues. It's common for the first attack of gout to occur in the first MTP joint, which we can see here. Later attacks of gout, though, can occur in any of our other joints. A lot of times you'll see it in the first MCP joint of the hand. Generally, gout is not evident radiographically until more advanced conditions of gout develop. So this is a pretty severe case of gout. Most cases of gout occur in men, and first attacks of gout rarely occur before the age of 30. So to summarize gout, just please know that it's a type of arthritis in which uric acid has excessively built up in the blood, which is then deposited in joints, and may be hereditary and more common in men. Next, Lisfranc injury. So I'll try to summarize the Lisfranc because it's a little bit complex, but the Lisfranc ligament is a large band that spans the area where the medial cuneiform and the first and second metatarsals meet. So in other words, here's medial cuneiform, first and second metatarsals are normally here, so the Lisfranc ligament is a strong band right in this area, okay? We know that the mid-region of the foot is prone to stress injuries by falls, accidents, sports, overuse. So Lisfranc joint injuries range from sprains to actually fractures or dislocations at the base of the first and second metatarsal, like you've seen here. So this would be an advanced or severe case of Lisfranc. A more subtle case of Lisfranc, you won't necessarily see fracture or dislocation. It's more of a ligament or soft tissue injury. A moderate sprain of the Lisfranc ligament is characterized by an abnormal separation between the first and second metatarsals. You may even see a small avulsion fracture, And if you see an avulsion fracture, that usually indicates a more severe injury is present. Liz Frank joint injuries may be missed if weight-bearing AP and lateral foot projections are not performed. And you can see here, again, there's significant displacement of the first and second metatarsals away from the cuneiforms, so they have a significant Liz Frank injury. Osgood-Schlatter disease. This involves inflammation of the bone and the cartilage of the anterior proximal tibia, or this area of the tibial tubercle. It's most common in boys between the ages of 10 and 15 years old, but I have seen this in girls as well, so it's not exclusive to boys, it's just more common in boys. Osgood-Schlatter disease affects children who are experiencing growth spurts and children who play sports in which they regularly run and jump. They're at a higher risk for seeing this type of disease. The cause of Osgood-Schlatters is believed to be an injury that occurs when the large patellar tendon detaches part of this tibial tuberosity to which it's attached. And it actually, you can see here, the patellar tendon kind of pulls that tuberosity away from the bone. Severe cases of Osgood-Schlatter require immobilization by cast. I've even seen screws here. And again, I can tell this is a child because look at the epiphyseal plates are still present. So again, younger people who are going through growth spurts or who are athletic tend to be more at risk for Osgood-Schlatters. Okay, Reiter syndrome. Reiter syndrome affects the lower extremities of the body. It can be found in the SI joints or the sacroiliac joints in our pelvis region. This is seen in men in particular, and the radiographic hallmark sign is bony erosion at the insertion point of the Achilles tendon on the posterior aspect of the calcaneus. So let me say that again. Reiter syndrome can affect the lower extremities of our body. We see this typically in men, and one of the classic or hallmark signs of Reiter syndrome is this erosion at the back of the calcaneus. And that is where our Achilles tendon attaches. Okay? Involvement is usually bilateral, so you'll see this in both limbs. Patients with Reiter syndrome have, their symptoms include arthritis, conjunctivitis or pink eye, and Reiter syndrome is known to be caused by a bacteria. Where does this bacteria come from, you ask? Well, it could be a previous infection of the GI tract, such as exposure to salmonella, or it could be from a sexually transmitted infection such as chlamydia. So interesting. Reiter syndrome really affects more than just our lower extremities. If you notice here are some effects on the skin of the feet on patients with Reiter syndrome. So this is really an unfortunate condition. Okay, next, osteomalacia. This is also known as rickets, which maybe you've heard of. Osteomalacia is a condition of bone softening, and it is caused by a deficiency of calcium and/or vitamin D. And that deficiency is either caused by a lack of healthy food in the diet of the individual, or the individual's body is unable to absorb the calcium and the vitamin D that they do intake. You'll see rickets in underdeveloped countries that also don't have months and months of sunlight. So think about Russia or some of the impoverished Eastern European countries. If families living in poverty don't have access to a healthy diet and also don't get vitamin D from the sun, that can cause or lead to rickets. So characteristic of rickets is this bowing in the lower extremities that you see here. And that's a result of the softness of the bones. Okay. We are going to pause here, and in part 2 of our pathology lecture, we will pick up with fractures of the lower extremity.